Bom dia! Estou começando o programa Infertilidade em Foco. Eu, Darcine, irei tratar um tema hoje muito importante: endometriose. O nosso convidado de hoje é um amigo muito especial, Dr. Hemant. Ele que está representando o país índio. Dr. Hemant é um conceituado cirurgião endoscópico ginecológico, com uma experiência de mais de 22 anos. Ele também delega várias conferências e workshops a nível nacional e internacional. Também é professor da Universidade de Pós-Graduação Hospital King Edward de Mumbai e professor no Centro de Treinamento de Endoscopia, IMMAST. E hoje, esse renomado professor e doutor irá dividir conosco o seu vasto conhecimento. E o tema da nossa palestra de hoje é endometriose. Vamos assistir?
Endometriosis is a condition in which the tissue similar to the inner lining of the uterine cavity, also known as endometrium, is present at abnormal locations outside the uterine cavity in the peritoneal cavity. Now, similar to the normal lining of the uterus, these implants of endometriosis, also known as nodules, respond in a cyclical manner to the hormones and cause a sort of a bleeding within the peritoneal cavity. This produces an abnormal reaction and inflammatory process within the peritoneal cavity, which leads to distortion of the normal pelvic anatomy due to sticking or adhesions of the organs together, and which completely distorts the normal pelvic anatomy. Endometriosis is an enigmatic and a puzzling disease, the exact cause of which is not known even after 100 years of its discovery. There are many theories, the oldest one that being of retrograde menstruation coined by Samson, but it did not stand the test of time and therefore it has been long debunked. The latest theory that sounds very logical and fits the bill is that of abnormal differentiation and migration of embryonic cells during embryonic development, which leads to crumbs of endometrium along the line of movement of the paramesonephric duct, which leads in the formation of the uterus, the vagina, and the reproductive. Misconceptions and myths around this disease of endometriosis, as it is poorly understood even by certain medical specialists. The commonest myth floating around is that pregnancy cures endometriosis, which is absolutely wrong. What pregnancy does is it causes temporary suppression of the hormonal axis, and therefore the endometriotic implants which respond to hormones become quiescent for a temporary period of time. Once the pregnancy is over, the endometriosis can come back again in full flow. The other myth surrounding endometriosis is that hysterectomy only cures endometriosis. Nothing could be far from the truth. Hysterectomy is not the cure of endometriosis. In fact, if you're just doing a hysterectomy and leaving behind the endometriotic implants, they can again regrow because these cells are very unique. Now, when I defined endometriosis, I said the tissue is like endometrium but not exactly similar to the endometrium. These cells at a molecular level, they have a unique property and characteristics. They are self-propagating, that is, they can grow on itself, they can produce their own estrogen, and they resist apoptosis. So something similar to cancer cells, but it is not a cancer condition, it is a benign condition, but these cells are unique, as I said, and they can invade locally into other organs like the bowel, bladder. So the conception or the misconception that hysterectomy cures endometriosis is not true, because if you're just going to do a hysterectomy and leave behind the implants, it will again grow. So what is needed along with the hysterectomy is radical excision of the endometriotic implants all over the pelvis and wherever you can see it, over the intestine, over the peritoneum, over the bowel, bladder, and the ureter. The other misconception surrounding endometriosis is that menopause cures endometriosis, because I mentioned that these cells are very unique and they can produce their own estrogen. So menopause, in spite of the fact that menopause causes suppression of the hormonal axis, these cells can produce their own estrogen and still propagate. So there are very few cases in the postmenopausal females you can see endometriosis. And the final misconception which is routinely floated around is there's some kind of a magic pill which cures all forms of endometriosis. This is again not true. Only certain cases of endometriosis, like the milder cases, might respond to the medical management or the pill. But when the disease is severe and producing a lot of pain, the best management is excision surgery for endometriosis. The main symptoms of endometriosis are associated with pain. They can be painful periods, they can be pain while passage of stools, pain while passage of urine, pain during sexual intercourse. These are all because of the endometriotic implants and the fibrosis which takes place within the abdominal cavity. Then there could be non-specific symptoms like bloating of the abdomen, which is also known as endobelly. There could be non-specific pains, muscle ache, chronic feeling of tiredness, and there are many overlapping symptoms. And because of this overlap with normal conditions or normal physiological conditions like menstrual pain, which might be considered normal in many females, there is a lot of delay in diagnosis of endometriosis, and it gets pushed or gaslighted by many medical practitioners also. And that's why when most of these patients present to us endometriosis expert, the disease is in advanced stage. So since pain is the main symptom of endometriosis, we need some method to quantify this pain. So for this we have the visual analog score, which the patient tells us a score out of 10, what is her pain score. From this we can gauge the intensity of pain, and any pain more than 7 to 8 on 10 has to be evaluated further. And if the pain is neglected over a period of time, what happens is a process known as centralization or somatization of pain, where the pain fibers are formed, and then after this long delay and chronic process of pain, even when you do a proper treatment like excision surgery, because of the pain pathways that are intact, the pain can still be there. And that is why it is very important that in these cases we do not prolong or delay the treatment of excision of endometriosis if required for the patient to improve her quality of life. Unfortunately, there is no screening test for endometriosis to triage patients and to pick them up early. This is because most of the symptoms of endometriosis overlap with normal physiological conditions, say like menstrual pain. And there is no specific test which can, point or, as a marker for endometriosis. Recently, there is a saliva test which has been developed by a French company, which seems to be very promising in helping us screen patients of endometriosis. But still, it is in the implementation phase, and we require long-term studies to make it a protocol and to incorporate it in our daily practice. The best way to diagnose endometriosis in the most minimally invasive manner is via imaging. There are two options. There is an ultrasound and there is MRI. Ultrasound is easily accessible, inexpensive technique, but what it requires is a trained ultrasonographer to interpret the images, which can be quite challenging for a routine radiologist. You need a person who is trained in picking up images for diagnosing deep infiltrating endometriosis. MRI is an expensive modality, but it does produce standardized image, and the pickup rate for MRI, including deep endometriosis, is quite high. Both the modalities are fine. The first line of imaging should be ultrasound, followed by MRI for reconfirming the diagnosis if and when required. The best way to diagnose endometriosis in the most minimally invasive manner is via imaging. There are two options. There is an ultrasound and there is MRI. Ultrasound is easily accessible, inexpensive technique, but what it requires is a trained ultrasonographer to interpret the images, which can be quite challenging for a routine radiologist. You need a person who is trained in picking up images for diagnosing deep infiltrating endometriosis. MRI is an expensive modality, but it does produce standardized image, and the pickup rate for MRI, including deep endometriosis, is quite high. Both the modalities are fine. The first line of imaging should be ultrasound, followed by MRI for reconfirming the diagnosis if and when required. Endometriosis is a very enigmatic and complex disease many a times there is a mismatch between the symptoms of the patient and the clinical findings. For example, a patient with mild disease might be having severe symptoms of pain, whereas a patient with severe clinical findings might have no symptoms at all. For this reason, the treatment of endometriosis should always be symptom-centric, focused on the symptom of the patient, the age group of the patient, the desire to get pregnant. So there are many options like the medical management, which involves giving hormonal drugs which suppress the hormonal axis and temporarily suppress the endometriotic nodules. But most of these treatments are temporary, and the moment you stop the pill or the hormones, the symptoms might come back. The other option is surgical excision of endometriosis using minimally invasive surgery. In this method, the nodules which are visible and palpable during surgery are excised systematically so that the load of the disease is optimally reduced. Once the load of the disease is reduced, the inflammatory process drastically comes down and thereby improves the quality of life of the patient and drastically reduces the pain score or makes it absolutely zero. The treatment also depends upon the type of endometriosis. There are different types of endometriosis. There can be an endometriosis involving the ovary known as ovarian endometrioma, in plain terms also known as chocolate cyst. The treatment for that is excision of the chocolate cyst if the size is more than 5 centimeters and if it is causing pain to the patient, or if it develops some sort of an abscess. There could be superficial peritoneal endometriosis where the peritoneal invasion is less than 5 millimeters, and there could be deep infiltrating endometriosis when the peritoneal invasion is more than 5 millimeters. So the treatment for deep endometriosis along with pain is always excision. As I mentioned, the nodules are excised systematically. Then there could be involvement of the bowel, the ureters and the bladder with endometriosis. When the bowel is involved with endometriosis, it could be superficial involvement where only the superficial surface of the bowel wall is involved, or it could be invading into the muscular layer of the bowel and could produce occlusion symptoms, thereby hampering the passage of stools and producing a lot of pain during passage of stools. In such cases, when the depth is up to the muscularis level, then that segment of the bowel needs to go either with complete segmental excision, or a part of the anterior wall which is affected is removed in the form of segmental excision of the bowel. If only the superficial wall of the bowel is involved without muscular invasion, a shaving procedure where the superficial nodule is just excised without opening the bowel, which has very good results and can be done in almost 90% of the cases. To tell you a bit about the role of an endometriosis excision surgeon while dealing with deep infiltrating endometriosis. We all know that endometriosis causes severe distortion of the normal anatomy of the pelvis due to its inflammatory process and producing fibrosis and adhesions. So when this distortion exists, it might be difficult for a routine gynecologist who is untrained in dealing with these kind of conditions to operate on such patients. And the data has shown that the risk of these surgeries having complications in untrained hand could be as high as 10 to 20 times. And that's why you need to really show yourself to a surgeon who is trained in dealing with this kind of pathology and in that detailed pelvic surgery involving the bowel, ureter and the bladder and other organs which are critical. So that is the role of an endometriosis excision surgeon who is trained in performing these surgeries, who is focused on dealing with deep infiltrating endometriosis and has a special interest in this branch. These are gynecologists who have developed the skill over a period of time due to their interest in endometriosis and do this excision surgery very efficiently and in a resourceful manner, thereby reducing the optimal bulk of the disease. And that's why it's important to show yourself to an endometriosis excision surgeon. But let me tell you, globally there are very few endometriosis surgeons who are doing a decently good job and with good optimal outcomes with less chances of recurrences. So you have to research before you go to your surgeon about the kind of work and the volume of work that they are doing. Endometriosis, in which the endometriosis exists in the uterine muscle layer. Because of this, there could be abnormal swelling of the uterus where the size of the uterus increases, And because of this, there can be a severe impact on infertility of the patients in the reproductive age group. Apart from this, it can produce heavy bleeding during menstruation and lot of painful cramps during menstruation. So the impact on infertility is tremendous because it prevents implantation of the embryo on the uterine lining, that is the endometrium. The treatment for adenomyosis is again medical management with hormonal suppression, but if the pain is too severe and there is cystic adenomyosis where there is cystic collection within the adenomyotic nodules which causes severe pain, then a surgical excision is the ideal choice. But surgery in adenomyosis is almost never done to enhance the results of fertility. These patients do present as difficult conception patients and have very low rates of pregnancy with IVF and ART also. So the impact of endometriosis on infertility could be very severe, not only because of adenomyosis but because of distortion of the normal pelvic anatomy and in general the inflammatory condition that it produces, altering the normal milieu within the pelvis, which impacts almost all factors of infertility like the tubal motility, the ovulation, the quality of the oocytes, the implantation of the embryo. My final message to women who might be or are suffering from endometriosis is never neglect your symptoms. Even though they might be dismissed off by medical practitioners, please consult an endometriosis expert if you are suffering or are suspected to be having endometriosis. Make an informed choice regarding the treatment options because it's your body and you have the right to decide what is the best for you. Having said that, you should also be doing the right treatment options available from an expert endometriosis surgeon or an endometriosis expert. And once you undergo a treatment, there should be a clear-cut follow-up plan over a long period of time and avoid the factors that might trigger your endometriosis.
É prazer receber e entrevistar esse renomado médico da Índia. Dr. Hemant Kanojiya irá tratar de um assunto muito comum entre nós mulheres, a endometriose. Vamos saber um pouquinho mais? Geralmente, as pacientes chegam no consultório e querem saber a causa específica da endometriose. Dr. Hemant, a endometriose é uma doença hereditária?
Hola, senores y senores. 10% of the female in the reproductive age group suffer from endometriosis. The worldwide incidence is 190 to 200 million women. Although it was discovered more than 100 years ago, the exact cause still remains unknown. There are many theories. There's definitely a genetic predisposition, as studies have found familial clustering as it can run in the females of a family. Apart from genetics, epigenetics also plays a role. In this, there is no obvious genetic mutation, but the expression of the gene is altered due to complementary factors like environmental toxins which can trigger endometriosis. So females with a family history of endometriosis should be more vigilant and should undergo an evaluation even with the slightest of symptoms.
Dr. Hemant, outra dúvida muito comum entre as pacientes é se há uma faixa etária específica para o surgimento da endometriose.
It is usually seen in the age group from 25 to 40 years, but in the last 2 decades we are seeing an exponential rise in the younger age groups like the teenagers. Also sometimes it can be seen in the postmenopausal females.
Doutor, a endometriose é uma doença que tem cura?
There is no known complete cure for endometriosis. It is similar to any chronic disease like diabetes mellitus. We can either control it with medical management, which temporarily suppresses the symptoms of the disease, or with surgical excision, which optimally decreases the bulk of the disease and causes great symptomatic relief. There are, however, chances of recurrences.
Quais são os sintomas da endometriose? Há alguns sintomas específicos?
There could be specific symptoms like dysmenorrhea, which is painful periods, dyspareunia, which is painful sexual intercourse, dyschezia, painful passage of stools, dysuria, painful passage of urine, and long-standing chronic abdominal pain. All these symptoms can be scored on a visual analog score or a pain score chart. Any pain more than 7 to 8 on 10 is considered as a red flag and the patient needs to undergo an evaluation. Apart from this, there could be some non-specific symptoms like bloating of the abdomen, also known as endobelly, lower backache, lower limb pain, muscle pain, chronic fatigue and tiredness, altered bowel habits mimicking that of an inflammatory bowel syndrome. Many of these symptoms overlap with normal physiological conditions, hence they are dismissed of even by medical practitioners, leading to gaslighting.
Dr. Hemant, há algum exame que o doutor acha que é melhor, mais viável para poder diagnosticar a mulher com endometriose?
Unfortunately, there is no screening test to detect and triage patients of endometriosis. The best non-invasive test for detecting endometriosis is imaging in the form of ultrasound or MRI. Out of these, ultrasound is the first line as it is inexpensive and easily accessible, but it needs a trained ultrasonographer. MRI, although expensive, gives standardized images and has a very high pickup rate.
Qual é o melhor tratamento para a endometriose?
In endometriosis, many a times there is a mismatch between the symptoms and the clinical findings. So treatment of endometriosis should always be symptom-centric, that is focused on the symptoms of the patient, the age group of the patient, and the desire of the patient to get pregnant. The options are medical, that is hormonal suppression of the disease, or surgical excision of the endometriotic implants by minimally invasive surgery. But please remember, when there is a compromise in the function of a critical organ like the bowel, the ureter and the bladder, then it requires an urgent surgery. So treatment for endometriosis should be customized as per the requirement of the patient.
Qual a relação da endometriose com a infertilidade? Todas as pacientes com endometriose têm dificuldades em engravidar?
Those suffering from infertility have 30 to 50% chance of having endometriosis, whereas those suffering from endometriosis have 50 to 60% chance of suffering from infertility. Endometriosis, due to its long-standing inflammatory process, alters the milieu of the pelvis, which affects all aspects of fertility, right from ovulation to the quality of eggs, to tubal motility and the implantation of the embryo in the uterus. To aggravate this, there is severe anatomical distortion which affects the relationship of the tubes, uterus and the ovaries, which again hampers fertilization.
Dr. Hemant, paciente com diagnóstico de endometriose e grávida. Como que vai ocorrer essa gravidez durante os 9 meses? Há risco de aborto?
Endometriosis mainly affects the implantation of the pregnancy, especially when associated with adenomyosis, which is nothing but endometriosis within the uterine muscle layer. But once the implantation takes place, the chances of losing the pregnancy due to endometriosis is very low. Don't lose hope if you're suffering from infertility. There's always some ray of hope and light at the end of the tunnel. But at the same time, learn to balance your expectations with reality and be pragmatic when dealing with infertility. Gynecology is a branch of medicine which deals with women's health, women that form the backbone of a society and are responsible for our future generations. India is a lovely country with lovely people. It is at the forefront of gynec endoscopy with some great endometriosis excision surgeons. I love my country, India.
Estou terminando o programa Infertilidade em Foco. Quero agradecer a todos os telespectadores da TV Faz, do Brasil e do mundo. Também agradecer ao nosso convidado de hoje, que contribuiu com muito conhecimento sobre a endometriose, que é uma doença que atinge de 10 a 15% da população. E com isso, eu agradeço imensamente a todos vocês que acompanham o nosso programa todos os domingos. Obrigada pela audiência, obrigada TV Faz e até o próximo programa Infertilidade em Foco com Belcine. Até lá!